Good afternoon, maybe good morning for some of you. Thank you for joining the Bipartisan Policy Center today for our event on optimizing Medicare-Medicaid integration for dually eligible beneficiaries. I'm Bill Hoagland, Senior Vice President here at the Bipartisan Policy Center. I have the distinct pleasure of working with our health program here under the direction of Marilyn Serapini, who is our Executive Director, and Lisa Hartushian, Associate Director. For over a decade now, BPC has worked to identify policies to improve care for dually eligible beneficiaries. This is a very diverse, a very heterogeneous group of individuals who are eligible for Medicare, but due to age or disability and eligible for Medicaid also based on income. There are nearly 13 million people who are jointly enrolled in Medicare and Medicaid today. They represent about 18% of all Medicare beneficiaries and 14 or 15% of all Medicaid beneficiaries, but disproportionately, they represent 33% of all Medicare spending and 12% of all Medicaid spending. Dually eligible beneficiaries often experience a very fragmented and uncoordinated care, contributing to poorer health outcomes and higher federal health care spending. I am struck by the fact that 9 in 10, nearly 90%, live on an annual income below $20,000. And I compare that to 20% of Medicare beneficiaries at that level. And more than half of all dual eligibles are persons of color, compared to only 20% of Medicare beneficiaries only. These challenges have prompted policymakers to make this program work better together, find ways to make them work better. There's been recent bipartisan efforts in Congress that have focused on integrating care for dually eligible beneficiaries. And quite frankly, obviously, we here at the Bipartisan Center hope that that momentum for bipartisan reform will continue. As you'll hear from our panel, there are multiple approaches to integrating care with potential for reducing costs and increasing beneficiary protections and ensuring necessary coordination between the states and the federal government to optimize these programs for the benefits of the beneficiaries. I thank the panelists for their participation today, and I personally very much look forward to their discussion. And finally, on behalf of the Bipartisan Policy Center, I want to thank the Commonwealth Foundation for their generous support of the work that we do in this area and for this event. I'll now turn this over to Rachel Newsom, who serves as the Senior Vice President for Federal, State, and Health Policy at the Commonwealth Fund, for her introductory remarks. Over to you, Rachel.
Thank you, Bill. Thanks to the BPC team, and thanks to all of you for joining us today. I'm Rachel Newsom, Senior Vice President for Policy at the Commonwealth Fund. For over a century, the fund has been committed to producing policy-relevant research and analysis. Our mission? Enhanced access to affordable, high-quality, equitable care for all Americans. You can visit our website, commonwealthfund.org, for more information on our areas of focus and for the latest publications and insights. The population we're focused on today, the roughly 13 million people eligible for both Medicare and Medicaid, is diverse and complex, as Bill mentioned. The policy options for improving the care experience for these beneficiaries are similarly diverse. We have a stellar panel positioned to help us navigate these issues, and we're so pleased to have Dan Gorenstein, the founder and executive editor of the podcast Trade-Offs, join as our moderator today. So Dan, I'll turn it over to you.
Thanks so much, Rachel. Thanks, Bill. It's a real honor to be here. My name is Dan Gorenstein. I've been a journalist for 20 plus years, including 6 years at Marketplace as the healthcare reporter there, and the last 5 running the national nonprofit news organization Trade-Offs. Our weekly podcasts are featured on NPR and based on numbers are among the most listened to podcasts in the country. Fun fact, more than 55 colleges and universities use our content in their classrooms. We love to say that the future leaders of the U.S. healthcare system, we're in their ears. We cover everything from drug prices to hospital consolidation to mental health parity to the duals. In fact, we produced an episode on the duals back in March, and I'm really excited to moderate this conversation. This is clearly a huge problem that our country needs to get a handle on. And as it stands today, very few people in our country actually are super familiar with this issue, with this problem. To that end, I'd like to talk about what this panel is not going to be today. This is not a technocratic conversation. This is not a chance to dive deep into the weeds. This is a conversation designed to help more people in our country understand the challenges and opportunities with these some 13 million people who are enrolled in both Medicare and Medicaid. And as these numbers have gone on, I mean, just to put this point on it, we're talking about spending $500 billion a year on these some 13 million people. That's about $40,000 per person. And yet for all of that spending, indications suggest people are often not getting great care. Part of what we are exploring today, not just the panel, but you in our audience, is whether there's a better, more effective, more efficient, humane way to deliver care and provide meaningful care to people. With that said, I'd like to dive into bios, and then a quick note to you in our audience. We have with us 4 fantastic people. We're all really lucky to be here. First, I'm going to introduce Henry Claypool. He's the policy director at the Community Living Policy Center at Brandeis and is a consultant with BPC. Hamy Tawarson is the executive director of the National Academy for State Health Policy, NASHP, a nonprofit and nonpartisan organization committed to improving the health and well-being of all people across every state. Dr. Jose Figueroa is an assistant professor of health policy and management at the Harvard T.H. Chan School of Public Health and assistant professor of medicine at Harvard Medical School. And then Carrie Brannock is the Deputy Director of the Medicare-Medicaid Coordinate Office, MMCO, which works to improve services for individuals duly eligible for Medicaid and Medicare. This is virtual. If it were not virtual, I'd say, let's give it up. Nice round of applause for our folks. I'm sure out there people are snapping or doing whatever, but it's really nice that these people are willing to give us their time and their energy and their expertise. We are put together a nice group of people who are actually passionate about thinking about this issue and trying to solve this problem. So my quick note to you, the audience, I just want to say that we really want your engagement. We'd like you to respond. Please feel free to send questions throughout the panel discussion using live chat on YouTube or on X, formerly known as Twitter, using hashtag BPC Live. So with that, Jose, first question to you. We got some of this set up from Bill, but if you could, at a high level, who are the duly eligible beneficiaries and what types of medical and non-medical challenges do they experience? And remember, this is a rule for all of you guys. Watch the jargon. Watch that jargon. Be careful.
I will try to be careful. I will try to be careful. So first of all, thank you so much for having me. It is a pleasure to be here. So who are the duals? The first thing has already been said. They are among the most medically complex people living in our country. 90% of them have multiple chronic conditions. We're talking about cardiovascular disease, diabetes, liver disease, autoimmune disease, chronic kidney disease, many of them on dialysis. Over 40% have some form of mental illness, which is highly concerning. And many of them have serious mental illness, including things like bipolar disorder, major depression, schizophrenia, or other related psychotic disorders. Now, about 40% qualify for the Medicare program because of disability. That means that there's a high prevalence of people having visual, hearing impairments. Many people have intellectual disabilities, the prevalence of frailty, prevalence of cognitive impairment and functional impairment quite high in this population. Which means that about 1 in 2 duals require help with doing even the most basic human things, including bathing, cleaning, dressing themselves, and help with eating as well. The second thing is, as also has already been said, they're socially vulnerable. These people are living in poverty. As was mentioned, 90% living on less than $20,000 a year. That means that there's a lot of issues with food insecurity, housing insecurity, transportation issues, And many, over 50%, are people of color, specifically the majority being Black and Latino people in that subgroup, which means that they're more likely to face issues of systemic discrimination and structural racism, which we know are alive and are alive in our country. And so if you put it together, we have some of the most medically complex and socially vulnerable people that are the dual eligible beneficiaries.
I really appreciate that, Jose. I mean, in one sentence, it sounds like you're describing people who really are struggling, really vulnerable at the margins of society. Is that just yes or no? Is that a fair way to say that?
Yes, no question.
And so, thank you. Carrie, to you, so we often hear that the dually eligible beneficiaries receive fragmented, poorly coordinated care. Before we talk about integration, I just want to help set the table for the audience a little bit. So these are people who are enrolled, right, in both Medicare and Medicaid. And at the highest level, what services do people go to Medicare for? What services do people go to Medicaid for? Again, I just want a table set for people who are just beginning to get familiar with this issue.
Sure, and I'm also very happy to be here. Thank you. Navigating two payers is challenging. Medicare is run by the federal government, and Medicaid is run by 56 different states and territories. They're distinct programs with different purposes. And as you said, this leads to fragmented care. There are misaligned incentives for payers and providers, and administrative inefficiencies in having two payers. Medicare pays for the coverage of most preventive, primary, and acute healthcare services and drugs. Medicaid benefits vary by state, but generally Medicaid pays for the coverage of long-term services and supports and certain behavioral health services. And then importantly, it helps with Medicare premiums and cost sharing. So I can lay out some of the systems level challenges, but I know a lot of the discussion today is going to be about how we're collectively working to try to solve for some of these. I think.
Go ahead.
Oh, I think one of the most significant underlying misincentives here is that for states, their investments in Medicaid services to try to improve care for this population, such as having enhanced behavioral health or home and community-based services to help keep someone out of a hospital, that this often results in savings that accrue to Medicare from lower acute care utilization rather than coming back to the state.
And sorry.
No, go ahead.
Okay, so I just again at this simple level, right? We're talking about people who are often forced to carry two insurance cards, use two sets of benefits, decipher two sets of rules. I mean, lots of us don't even like to deal with that with one insurer, and these folks who, as Jose was explaining, are super marginalized, have to deal with two sets of these things. So a lot of thinking and a lot of energy and a lot of resources, particularly over the last decade, Carrie, have gone into this idea of more integrated care. Can you, again, walk us through at the high level, what does integrated care mean? Again, conceptually, without getting super specific.
Sure. It depends on who you're speaking to, but I think for my office, integrated care means that, one entity or organization is accountable for the total cost of care across Medicare and Medicaid for an enrollee. I think this most common sort of manifests in different capitated arrangements like PACE program, the Financial Alignment Initiative demonstrations, or in Medicare Advantage more broadly, there's a type of health plan called Dual Eligible Special Needs Plans, or DSNPs.
DSNPs, love them.
Yeah, that's probably an acronym we'll be unable to avoid on this discussion.
Yeah, and so we'll get to some of these challenges around integration, but just so we're clear again for everybody, integrating means how can we, is it fair, Carrie? Integration really is shorthand for how do we create a more seamless insurance provider experience for the duals?
Yes. And I think it comes down to the person. We want to try, even though these are two distinct systems, two distinct payers, we want the experience of care for the individual to feel seamless and to try to find opportunities to try to reduce that fragmentation and solve for some of those misincentives in the system.
Right. Make it easier for these people and figure out some of this work on the back end. Hammy, nice to see you. Would really love to hear from you talk about the state role in integrating care for beneficiaries and the range of different models states have considered as they look to provide this more seamless experience that Carrie's talking about. Because there's a lot of diversity out there, right?
There is. And first of all, I'm so happy to be part of this panel. It's a great topic and an important topic to talk about. Just to say my remarks today, NASHB, we are a nonprofit, nonpartisan organization that just works really closely with states. So everything I'm going to talk about is really coming from the state perspective and how to improve health. And I'll just say the topic of dual eligibles has been a longstanding topic for states. As well as the federal government, and thinking about how do we really better serve this population. We've heard about how complex they are, how vulnerable they are, and the complications between the two programs. And I'll say, I don't think we have the silver bullet yet. I'm just going to be very honest in terms of, this is exactly the model and this is how it's going to work. And so states have really tried different ways to better integrate care. And we're going to talk in a little bit about the challenges to that. But I'll just say where we are right now, I feel like is on the cusp of managed care having more of a presence. So that's, managed care plans that serve dually eligibles. Carrie talked about them, DSNPs. There are more of them. There are more people enrolled in them, but they're still not the dominant form of care for people. And so a question for states now is, what direction do we go? How do we really make sure we have integration across the two programs? And what's the structure that we should use? And I'll just say, the past number of years, there's been 10 states that have tried what's called the financial alignment model that Carrie talked about, where you had one plan that was paid. Medicaid states could share in savings if they did, were able to provide more home and community-based care and had some savings there. But the enrollment was fairly low and there were mixed results. So I think those programs are going to sunset in 2025, and not to get too wonky. No, we're trying not to. And so now states are thinking about where do we go next? And I'll just say, I'm a Medicaid lawyer. I've been doing this for a long time. I find this area so complex in figuring out what the different options are. And if you think about how that then applies to the average consumer, they have so many options, even just on the Medicare side. They can be in Medicare fee-for-service, they can be a Medicare Advantage plan, or they can be in a Medicare Advantage plan that serves duals. And there are many different options across states. And then on the Medicaid side, they can be in Medicaid fee-for-service. They can be in a Medicaid long-term services and supports plan, which is basically a managed care plan that gets a capitated payment to provide those long-term services and supports. So there's so many different options and so many different variations. I think it's hard for consumers to navigate. States now are moving towards more people are going to be enrolled in managed care on the Medicaid side. We're seeing some increases there. And there is, I think, interest both on the federal government side and the state side of we should coordinate that enrollment on the Medicaid side and managed care plans with a Medicare plan that's a DSNP that really is focused on dual eligibles. And so what we're seeing now is this transition of states really being able to have some oversight and making choices about who to contract with on the Medicare side and DSNPs in particular. And I think there's opportunity as well as challenges, which we can talk about later, about how to truly ensure that at the end of the day, the consumer is getting good quality integrated care that is, reducing costs.
Amy, just to follow up on this, you covered a lot of ground there. What's the big question? And obviously, a lot of states have different approaches, but as you look to sort of many states, what's the big question they are grappling with now when it comes to the duals? Is it, do we work with private insurers to offer a more seamless plan? Is it, or should we like work with, do some more homegrown thing through our own Medicaid program? What is that question that people at the state level just don't know what the answer is to right now?
Yeah, so I think there's a couple of states, and I was going to talk about them a little later, but I can talk about them now, who have long invested in, we are going to have an integrated plan where, just give you an example, on the Medicaid side, there's a managed care plan that covers the dual eligibles. And then they're requiring that Medicaid plan to also offer a Medicare plan to provide the services on the Medicare side. So it's coordinated. That's one model. Not every state has sort of gone down that path. And so now some are thinking about, okay, we have some, dual eligibles who are in our Medicaid fee for service. We have some that are in our managed care plans. And do we then contract with certain types of DSNPs? There are different types. There are some that are fully integrated. There are some that are highly integrated, and there's some that are coordinated. I know we're trying not to get wonky, but that's the reality. And I think different states are opting to contract with different types of plans in different ways. So I would say the question there is, which type of plan is going to be successful in our state? Where do we have enough of them? Do we have the capacity to contract and effectively oversee those plans where we can put things into their contract to make sure they're integrating, et cetera? And what are the outcomes? So which option is the best for the different populations that we serve?
Thanks, Haney. I really appreciate that. What I'm taking from this, and this is for our audience's purpose, like, states are really asking themselves, what type of plan should we work with? What sort of oversight is required? And finally, what's the evidence? What's the data? What's actually there? Thank you very much for that. So Henry, let's talk to you for a quick second here. Not a quick second, actually a long second. From a beneficiary's perspective, what are some of the most significant hurdles encountered by people, by these duals, while they try to deal with all of this mishigas?
Sure. I think first it's important to really center these beneficiaries with the most complex need in our conversation today. And the group that I'm going to talk about largely is, you've already heard from Jose about kind of the complexities and the types of conditions that they live with. But they rely often on these long-term services and supports, or home and community-based services, and behavioral health services, mental health and substance use services to live in the community. Keeping them at the focus is really important. But we need to understand that Medicaid is really the only significant payer for these home and community-based services. And in the behavioral health arena, they're really the only space, the only payer that has much familiarity with paying for these services on the ground where people live. So we have to take on the kind of historic challenges of working with Medicaid, which is these have historically been optional services. And so states are not always making them available to everyone that needs them in the Medicaid program. But the majority are getting some shape or form of these home and community-based services in the community when they need them. But again, there is no real guarantee because they are optional services and the state has the prerogative to take them up. The other factor that comes with the Medicaid program is—
Henry, let me just pause you here because I want to ask you one quick follow-up before about the behavioral health point you just made, and then you make this next point that you just made that you want to make. So are we seeing, as more attention gets placed on the duals and the challenges with the duals and the spending on the duals, which obviously is incredibly important to state budget writers, are we seeing an adaptability on the part of state lawmakers to be more open-minded when it comes to offering more behavioral health services to the duals, having some sort of carve-out or whatever? Is there any movement there, or are we sort of starting from ground zero?
there's certainly movement, but we have this foundational challenge where there's a huge amount of stigma around these services, and we have decades-long policy that has resulted in underinvestment. So when we turn to provider networks and ask them to serve these populations, we really find a dearth of them available. So states are often in a position where they are trying to build provider networks that are going to be able to deliver the capacity of services that are needed to address people that are unhoused, that have substance use issues, that may be dealing with significant mental illness. So we know in our society kind of these challenges, and yet we still have these legacy issues that we have to deal with around stigma and the fact that we haven't historically paid for the services the same way we have other health care services.
And one final, very quick on this, just because people in the audience might be curious, if there's any state that's really kind of like modeling how to deal with this and figuring out the path forward, sort of providing this behavioral health service, is there one state that you could share with the audience that other states could look to as a potential model here for how to do this work in a meaningful way?
You know, I'd hesitate to pick a single state, but I think there are populations where we've made more significant moves. And I think that is those that are living with chronic and persistent mental illness is a label that some people bear. And when they're able to get active community-based treatment, where teams are actually in the community, helping support them, peer networks are surrounding them, really reinforcing the types of behaviors that will allow them to stay in housing, we find those states really achieving some better outcomes for this population.
And I don't want to put you in an uncomfortable position. You might not know the states. You might not really want to be willing. But if you could share, if you could be more specific about a group of states, put it in the chat or share it with BPC later. I think people would probably be interested and want to know, because obviously everybody's in this race to find meaningful solutions. But let me just, I know there was one other point you want to make. If you could make that, and then we'll move on to the next set of questions. I apologize, but thanks for letting me ask these follow-ups.
Sure. I think my main point here is that policymakers are really beginning to come to grips with the kind of shortcomings that I've raised here about these primarily Medicaid services, simply because they know that this population has the most complex needs. And if they're going to be able to contain costs and deliver better care, they really need to begin to grapple with the shortcomings that I've identified. And they're both in the Medicare and the Medicaid benefit.
Great, thanks, Henry. And Hammy, you want to make just a quick comment here for the audience?
Yeah, just on the behavioral health, I totally agree with Henry about this sort of historical underfunding. I will say, coming out of the pandemic, we have seen states really try to invest in their behavioral health networks and try to think differently about behavioral health, but it's going to take some time. And I just wanted to call out, I don't have favorites among states, but I think there's just a couple of ideas. Massachusetts is a state that has really built out a roadmap on behavioral health. They've also done a lot of work on integrating care for dual eligibles. And so I think our hope is the combination of those efforts can really help move the needle on providing behavioral health services to dual eligibles. And then I'll also call out another state. North Carolina is one of a number of states that have really focused on increasing the behavioral health payment rates for providers and trying to build that network while thinking about how to ensure access in communities. So there's a number of states that have made big investments in behavioral health. We'll see how that all pans out, but just to share two ideas on sort of the behavioral health piece.
Great, thanks for that, Hammy. We're going to move on to a next section of questions, which is labeled "Valuable Lessons to Shape the Way Forward." Jose, we're going to start with you. Considering the available evidence on various policy approaches to integrating care, what approaches or models stand out as successful or as close to successful as we get in the dual space in improving outcomes for people while addressing costs And I've got a little bit of a follow up to that, but let's just start there. What models or policy approaches are you seeing as the most successful, even if they're not like wildly successful?
Yeah, so the first thing I just wanted to clarify is that, you know, when we talk about integration, there's financial integration, but that does not necessarily mean that the healthcare system or the healthcare delivery side is integrated. When the majority of the time, when in the dual space, when we, you know, integrated care models often are only, as was mentioned by Carrie earlier, really trying to just create a one bucket of money, one entity, one organization responsible for total dollars, both on the Medicare side and on the Medicaid side. And the question is, why does it matter? And from the healthcare delivery side, it matters because it is really hard to do coordinated, efficient care if the healthcare system is unable to sort of work with the payer, you know, in terms of like organizing care for duals. And so that's just really important. And the majority of the integrated care models, again, are not are just financial integration. There's only one model that is arguably both healthcare delivery system is organized plus the financial integration, and that's the PACE model. And I know I'm supposed to avoid acronyms, but PACE is one where you could argue there's integration on both sides. The big issue with PACE, it is really small. There's only about 60,000 duals in PACE programs out of the 13 million. So the majority of people are not in a quote unquote both integrated healthcare delivery plus the payer side as well. So just to give you an example of why it matters, I work in the hospital, and when I discharge someone, sometimes they need durable medical equipment.
Yeah.
And sometimes, you know, if I'm trying to get a person durable medical equipment in a non-integrated world, I have to submit a prescription to the Medicare side. The dual person has to wait for that prescription sometimes to be rejected before maybe the Medicaid side comes in and pays for it. Now, it's really frustrating as a provider and also for the person to just be waiting, knowing the fact that, you know, that we have to go through this sort of fragmented, bifurcated because of the fact that, but as a physician, all I care is that, you know, this person needs durable medical equipment so they can be safe at home. Sometimes this means it's a prolonged hospitalization. They're at risk for deconditioning in the hospital. They're at risk for delirium. They're at risk for you know, infections at the hospitals. They're not necessarily a safe place to be for a very long period of time. Sometimes we have to send them to a nursing home instead of home because they don't have the right equipment at home. And if they do go home without the appropriate equipment, you worry about a risk for falls, a risk for, like, you know, their safety, and a risk for coming back to the hospital. So even simple things like, you know, like who pays for a service that the patient needs, it takes a long time to figure that process out.
And let me just jump in real quick to give the audience a second to digest what you've just said. I think your point, but correct me if I'm wrong, is that financial integration is essential here, but so is medical services or care services integration. And without both, then we may, if we only have financial integration, then you, as you've seen firsthand as a doctor in Boston, people will suffer. People's health will be harmed. There will probably be excessive, inappropriate, wasteful spending as well, possibly. And so you're saying, hey, as we think forward, as we think about solutions, it must include both a financial integration and a medical integration component. Is that your point?
Yeah, I think it's yes, we need to solve both issues, not just financial integration, but we also need to solve the integrated care side from the healthcare system side as well. But again, without the first step is financial integration, because without it, it's really hard to do the second step, which is the care delivery organization. And just to remind you, it's like, you know, it's like we have a system that's structured for the convenience of plans and the convenience of healthcare providers, not the convenience of people. As people, when you need care, and if your insurance covers it, you just want that care to be given, and so we need to figure out how to design both the payer side and the provider side to work for patients, to optimize care for patients. Now, so you asked a question in terms of the key features of what models work.
Right.
The first question, the answer though, is that the data on the evidence of integrated care models that, as I said, mostly organize just the payer side, is surprisingly very limited. We have some work with a colleague at Penn, Eric Roberts, who did a systematic review, and I'll just highlight that the evidence across integrated care models. The first thing is that the evidence looks pretty good in the sense that they reduce long-term nursing home admissions, meaning they keep people living longer in the community by promoting possibly better outpatient care, by promoting home healthcare services, community services at home. The data on care coordination is very, very limited, mostly because it's focused on measures of utilization and not true measures of care coordination. So, for example, readmissions is considered a measure of care coordination potentially, but in reality, it's just a measure of utilization. So there's not great measures on this. The data on patient satisfaction, patient experience, and patient and important outcome like mortality is also very limited. But the studies do suggest reassuringly that they're pointing in the right direction. So we think maybe patients are reporting better satisfaction and maybe having better outcomes. But again, the data is very limited. Most of the time is because these studies are not using randomized controlled trials. There's issues around confounding, study limitations. So the data is not a slam dunk towards integrated care models, but I think we're still really early in trying to uncover which models work and which ones don't. And so we just need we just need better data to figure out what works.
And just a super tight question response on this, Jose. Whether it's a glimmer of hope or just like closing a door and reducing the options, which in and of itself can be considered a win sometimes in research. What is the one study you would point the audience to that you feel like has helped you think more clearly, more sharply about the path forward, and why?
Yeah, so
real tight on this.
Yeah. So the one thing I'll say is maybe look and wait for the study led by Eric Roberts on this issue, because he does a great job summarizing. The short answer is we could not find one perfect study that did this, because there's so many limitations across the board. The majority of them being the fact that this is not that most of the studies are not randomized control trial. There's problems with all of them. But the summary suggests that in general, what we think is that we're looking for things that should be present in these integrated care models. There's key features that are suggestive of things that work. The first key feature is that they should be fully aligned, meaning it should be one parent company, because surprisingly, there's some integrated care models that are calling themselves integrated care models, but in fact, it's two separate companies forming a partnership. But in reality, it's not one entity that controls both dollars. So there's concern still for perverse incentives to maybe shift costs from one organization to another. We'll see if that, but that's one issue. The other concern thing, it's like when you look at a lot of the integrated care models are managed care models, meaning it's like Medicare Advantage companies. And there's a big concern that there's predatory marketing and ghost benefits in many of these plans. And then there's also concerns that there are ghost networks or inadequate networks. There was a comment made earlier that a lot of these plans are not offering in-network behavioral health specialists, which are very limited, which are very needed. The other thing I'll say is that there's concerns for potential evidence of profiteering. So they're putting the business side first over the. And now this one's not part of the study, I should say, but it's sort of the concerns that we're looking into. So one example is we're seeing PE firms, private equity firms, moving into the space. And why are PE firms moving into the space, for example, at owning PACE organizations? And in my mind, history has told us, especially PEs currently in healthcare, is when they come into a space, we should be concerned, because there's a lot of evidence, for example, in the hospital space, that when they come in, quality of care suffers. And so that's something that I think we should keep in mind moving forward.
Thank you. Thanks. Okay, moving on here. I know we're beginning to run a little tight on time. Part of that's because I'm asking all these follow-up questions. So I'll try to limit that. Hammy, you've spoken about states' options. There's lots of them. What are key federal supports that states need to overcome the barriers that the states are facing?
Yeah, so just to speak a little bit about the challenges that states have. So I really do agree with Jose's comments. States have limited resources themselves in terms of being able to effectively have oversight over these really large and frankly, larger and larger integrated managed care plans. Using the word integration differently, managed care plans are quite complex businesses now. And so states really need help in figuring out how can we effectively oversee these plans, that they're going to be there are more of them, they're going to be more duals enrolled in them, and what do we need to look at to make sure that the care is really being provided to the beneficiary in a way that we know is going to improve their outcomes and reduce costs. So I'd say from the federal government perspective, and the federal government's already started to do this and invest in this, is more technical assistance and resources for states to understand the market of integration and how to better oversee that. Where do they need to invest strategically their resources? And that includes like, what sort of, metrics should they be using to really figure out, is the care being provided as it should to the beneficiaries at the end of the day? I think the other piece that states struggle with is really having the expertise on the Medicare side. States run Medicaid, right? They don't run Medicare. And so, as they try to oversee these plans and understand integration, they don't always have the Medicare expertise. So having some of that support from the federal government, which includes increased access to Medicare data and really understanding how the programs can work together, I think is important. And then I'll just say two more things, and then I'll stop, is really understanding consumer experiences and outcomes. There's been different evaluations of different integration models, but how do we really have a benchmark of where should consumers be? Like, what is the outcomes that we want? What does good care look like? And how can we have more of a national benchmark to think about that as states then evaluate how they're doing in their individual states with their dual eligibles? And the last I'll say is, and Carrie talked about this earlier, there are some states that have done a really good job in rebalancing, providing more services in the home, like outside of like more costly settings of care, like hospitals or nursing homes. The way the program's structured, moving forward, it's really hard for states to reap the benefit of the savings of those investments. And so what can we do to think creatively about how to ensure that some of that, those savings can come back to the Medicaid program to ensure they can continue to reinvest, and really think about how to look at integration models in the future.
Thanks, Hammy. And Carrie, I've got a teed up question, but I'd like you to respond to what Hammy just said there, in terms of, in as much as you can, in terms of the federal government being in position to provide more technical assistance, as an example, more expertise on the Medicare side, understanding consumer outcomes. Is the federal government, how well positioned is the federal government to meet some of these needs that Hammy just outlined?
Yeah, I agree so much with what Hammy shared there. We are working to provide more technical assistance and partner with different state Medicaid agencies because the markets have really grown so incredibly complex over the last 10 years. One of the speakers mentioned it earlier, but it is like an alphabet soup of different options that beneficiaries have in choosing how they receive their Medicare and Medicaid. And this just proliferation of plan options and the existing ability of dual eligible individuals to be able to change Medicare plans more frequently than Medicare only enrollees has just left this vulnerable group susceptible to aggressive marketing tactics and just an incredibly complex market of choices. And so we have taken steps in recent rulemaking a few weeks ago to try to help states and help simplify markets. I can talk a little bit more about that, but you mentioned you have another follow-up question too.
Sure, totally. And I appreciate you thinking about the time here, but I would like, you dangle that out there, the opportunity for you've taken some steps in recent rulemaking. When you think about some of the needs that Hammy articulated states have, what's just one concrete step that has been taken in rulemaking that you think goes as far as possible in addressing some of these concerns and needs states have?
Sure. Well, a couple of the speakers touched on this, but having dually eligible individuals that are in managed care enrolled with the same health plan for Medicare and Medicaid is important. We believe it's better to have one organization accountable. And unfortunately, over 80% of duals are actually enrolled in two different organizations for their Medicare and Medicaid. And so a few weeks ago, we finalized a set of rules that over the next few years will increase the percentage of dually eligible individuals that'll get Medicare and Medicaid from the same organization. It will also reduce the total number of health plans that are targeted to this population, hoping to sort of simplify and reduce that choice overload of options in certain markets. And we've heard from states, and we're working on changes to Medicare Plan Finder to try to make it simpler to find these integrated options. Congress has given states the ability to choose who they contract with for these DSNP plans and the service areas of those DSNPs. And basically what the federal government is sort of coming behind to do is to try to restrict those health plans from only offering one DSNP in the service area where they have these Medicaid contracts. And we hope that will help sort of reinforce the state efforts and will, over between now and 2030, hopefully pretty significantly improve the number of beneficiaries and that aligned coverage that we've been talking about.
Great, thanks. And so to the actual question, again, we're trying to think about valuable lessons to shape the way forward. Carrie, what have we learned from the Financial Alignment Initiative and other integration efforts, including what policy approaches are promising or effective for improving access to integrated care and quality of care?
Sure. We've learned a lot over the last 12 years from those demonstrations and from our state partners and advocates and providers and enrollees in these different markets that have been participating. And it has been one of the biggest drivers towards the rulemaking that we've done over the last few years, where we've been trying to take what has worked well in the demonstration and apply it to dual eligible individuals in Medicare Advantage more broadly, or in DSNPs more specifically, depending on what it is. Some of these examples are things like that we've sort of taken from the demonstrations. We passed rules that now require DSNPs to have enrollee advisory committees in every single state, and we're providing technical assistance to the plans and to states on how to leverage those committees. We now require that all Medicare Advantage special needs plans incorporate questions into their health risk assessments from certain specified screening tools on housing stability, food insecurity, and access to transportation starting this year. We've taken the simplified appeals and grievance processes at the plan level that we had in the demonstration and extended that to DSNPs that cover Medicaid benefits for their enrollees as well. So we tested it in the demonstration, but Congress also directed us to do this in the Bipartisan Budget Act of 2018. But it means that a much larger population of duals now have a more accessible process to go through, and it also extended the protection of the continuation of Medicare benefits pending appeal to more people. We've expanded use of integrated beneficiary communication materials. So when you are in that aligned coverage, having one set of member materials, one evidence of coverage, one member ID card. And we're working with more and more states to roll those out, and have also passed regulations that require plans to translate those materials into many more languages in the past. And I think the last piece that really big lesson for us from the demonstrations is that joint oversight of managed care products is possible. And, we have a lot of room to go on this, but we're pushing on all fronts to try to work better together with states on that oversight. And I think that it can help provide a platform for quality improvement. For example, we worked with the demonstration in Ohio and the Ohio plans to try to incentivize better control of HbA1c levels. And through that effort, we saw all of the plans improve in those performance rates. So we've done similar things with flu vaccination. And so I think there's a lot of opportunity there to work more closely with states. And that's an area that we're hoping to do more.
That's great. I really appreciate that, Carrie. And I was a follow-up, but I want to make sure we get to Henry here, and maybe I'll loop back to you. Henry, are integration models effectively meeting the needs of the dually eligible, particularly folks with disabilities? Let's start there, and then we've got a second question in here.
Well, I think, there's a lot that could be improved. And I think we're seeing signs that steps are being taken to make those improvements. And I would just, look to the kind of the DSNP model, the special needs plans, and states that have been working with kind of a full integration approach and call out 3 features or characteristics that have emerged. Particularly in the state of Massachusetts, that I think would really help to improve the experience of the beneficiary in this exercise of trying to get access to better integrated care. And first, it's important to think about how we're going to improve the behavioral health networks. And one way is by really convening an implementation council that consists of a full range of stakeholders, but also includes the advocates for these beneficiary populations, so that we can have people holding policymakers at the state and in the plan level accountable for the services that they're providing if they aren't meeting the needs of the individuals. Second, I think it's really important to think about a genuine person-centered process that develops a care plan where you really take the time to visit with the beneficiary in their home to understand the type of supports and services that they rely on day to day to go about getting their basic healthcare needs met. Once we have an understanding of that and develop an appropriate plan of care, then you have a greater pathway to integration and a better chance of success if you're going to want to make sure that the beneficiary using the wheelchair gets the repairs in time so that they can actually make the transportation arrangements to get to the doctor's office for the visit with the clinician. And I think finally, or third in here, I would just mention the importance of the coordination of these long-term services and supports, the home and community-based services, the behavioral health services that allow individuals with these really complex needs to get the services and supports in the community so that they can stay there instead of being transported to a clinical setting for urgent care or something of that nature. This is where you can start to deliver some of the community-based preventative care that hopefully will yield the longer-term outcomes of cost savings. The challenge is we're doing this in an environment where the health plans are really looking at year-to-year enrollment and making decisions on whether or not they've got return on investment. So I think we do have some of these fundamental challenges to make sure that plans can stay in this for the long haul if they are going to be the ones serving these populations.
Thanks for that, Henry. We have an audience question I'm going to ask, and I think it's going to go, Carrie, to you. The question is, will this rule that you just mentioned carry, that they have to be managed by the same plan, still allow them to contract out services? If you could answer that quickly, we just have 2 minutes left, and I want to ask one final question for all the panelists.
Yes, if I'm understanding the question correctly, yes, the plan could still choose to contract out for services. Though I guess I would caveat, unless the state's contract with that DSNP had more prescriptive requirements for how the plan delivers those services.
Great, thanks. And just in these last, if everybody could take 30 seconds on the panel, part of the idea behind today's conversation is to find solutions, meaningful solutions to a very, very difficult, thorny, wonky problem. One thought that has been around for a long time is that integrated plans are part of the solution. I'd like each of you to go through and give us in 30 seconds or less why you are bullish on integration. What's one concrete thing that has happened that leaves you bullish about integration?
I'll start. I think without integration, there is no motivation for one side to invest in things that patients need, that providers think they should get, and that that might not that they're not going to want to invest in if the savings or the efficiency gains are not within the one side that's paying for it. And so there's little incentive for a Medicare Advantage company to pay for something that's costly if all of the efficiency gains and the savings are on the Medicaid side. So there's also some perverse incentives to cost share from, and it just doesn't make any sense from an efficiency standpoint to have two buckets of money.
Okay. Quick, who's next?
I can go next. So there are some states, and I didn't even call them out, Arizona and Minnesota, two examples that have had integrated care for a long time. And they have, to Henry's point, they've had 70% spend on home and community-based services, much higher than some other states. And so to me, that is evidence of, and lower, ED admissions and all of that, and nursing home use. So to me, that's evidence if you have some financial alignment where you're making a plan on the Medicaid side, actually offer a plan on the Medicare side through a DSNP, and providing that sort of integrated approach. In Minnesota, it's one card that the beneficiary gets. It's going to be a better outcome for that individual. And so how do we simplify these really complex systems so at the end of the day, the individual can get their care through sort of one mechanism that then, of course, to Jose's point, can share also in the sort of investments and savings that can result from that.
Super quick here.
I think, I think where we can take, the pressure off the individual and their family and support system at having to try to navigate the two payers and create a more efficient, aligned system, all the better, because we're talking about, as we've discussed, some of the most vulnerable populations here.
Henry?
Yeah, I would just jump in and say that we have to look realistically. People are enrolling in these plans, and they are, statistics show, the most vulnerable and marginalized populations enrolling in these MA plans that are looking for these services. And we have to continue to evolve and tweak the regulatory framework to improve the outcomes so that we get the value that the Medicare and Medicaid program are already putting in on these people's lives. And I'm confident that over time, we can get there using a regulatory framework like what's evolving in the fully integrated duals approach.
Great. Thank you all very much. Let's give it up for the panelists. I know we're at time here. Thank you all very, very much for a very honest, candid, decidedly not super crazy wonky conversation. Good 101 for folks. Thanks to Commonwealth Fund, to the Bipartisan Policy Center, and to you, our audience, for being here and wanting to get your hands and arms around one of the most pernicious, important questions that is challenging health policy today.